From Microbe TV, this is TWiP, This Week in Parasitism, episode 245, recorded on October 4, 2024. I'm Vincent Racaniello, and you're listening to the podcast about parasites. Joining me today from New York, Daniel Griffin.
Hello, everyone.
Not in the dungeon.
No, I'm up here. I could see out the windows. They let me out for a little while.
It's a dangerous undertaking. Also joining us from Glasgow, Scotland, Christina Nowla.
Hello, everybody. I can see out of the window too, but it's pitch black. But it's been a wonderful October so far. And I'm back in Glasgow. I'm not in Cape Town this time.
We have a guest today for you. He's the founder of Floating Doctors Ben LaBrot. Welcome to TWiP.
Thanks so much. Happy to be here.
Where are you?
I'm actually in Sao Paulo right now, wrapping up some hepatitis work here, and I'm headed to Lima, Peru tomorrow for the R4P AIDS conference.
Great. All right. Well, Daniel, what is the case from last time? Remind us.
Sure. So for those of you tuning in for the first time, those of you tuning back in, this is actually a case that Ben shared with me. So he's going to have to do the unveil at the end. Looking forward to finding out what this actually is. But this case comes from Panama, midsummer 2024. A provider for floating doctors working in the coastal region in northeast Panama sees this case, which involves a 1-year-old. So the history is a bit difficult. Maybe not just age. There might be some other factors that made it difficult to get much of a history from this 1-year-old. There may have initially been a scratch or some sort of break in the skin. Otherwise, this 1-year-old is healthy, but over a period of time, this area expands, becomes a deep necrotic wound on the leg. Several other nearby wounds develop, become deep and infected. By the time this 1-year-old is seen by the provider, much of the leg appears eaten away. This is just, as I mentioned, just the tip of the iceberg, as a number of others have developed similar wounds in this area. We learned that there was no prior medical history. There were a few questions. One was about like diet and other health. And I had mentioned this 1-year-old ate a lot of soup. And I don't know if that was much of a hint, but we had a number of guesses.
All right. Christina, can you take the first one?
Yes, I can do that. So Kimona writes, "Greetings, TWiP team. It has been a while. I've completed that fabulous TTMH course that Prof. Nowla introduced through the University of Glasgow. That'll be me, but I'm not a prof. I'm a senior lecturer. But thank you for the promotion." But I'm still stumped by this case. Sorry, Christina, not a reflection on the course or your teachings. The communities that Floating Doctor serves are in the archipelago of northwestern Panama. Did you not say northeastern?
It's really kind of eastern, right? Yeah, it's on the Atlantic side.
The Caribbean side.
Panama, which is an equatorial coastal geography. I spent a few weeks with them again this summer. I have 2 contenders, but I'm not sure either truly fall into the parasite category. Mycobacterium ulcerans infection, or Buruli ulcer, can be seen in coastal tropical areas, more commonly in Africa and Australia, presenting as a painless, enlarging ulceration, often on an exposed limb, that can lead to underlying osteomyelitis. But I doubt it would cause this rapid necrosis and destruction unless an underlying immune compromise exists. Strep or staph infections can occasionally cause a necrotizing fasciitis, aka flesh-eating bacteria. But multiple people in this community are now presenting with similar symptoms, thus hinting toward a common exposure. Vibrio vulnificus, a gram-negative rod, is found in warm and marine environments and enters broken skin from water exposure or through ingestion and contact with contaminated seafood. Do these people harvest shellfish? Lesions are commonly seen on exposed areas of legs and hands and can progress to ulceration, gangrene, necrotizing fasciitis, and sepsis and death if untreated. Diagnosis is through wound culture and PCR. CDC recommends treatment with ceftazidime plus a quinolone or tetracycline, along with aggressive surgical debridement. Sadly, the mortality rate remains high and reaches 100% if antibiotics are delayed. Mucocutaneous leishmaniasis also leads to invasive ulceration, but its location favors mucocutaneous skin. For any listener who's considering the DTMH course, I highly recommend it. Tons of great material released weekly in superb instructors, and a visit to Glasgow for their microscopy instruction, and plentiful pups. Eager for the reveal. Warmly, Kimona. I got a bit of advertisement there. Thank you, Kimona.
They do have great instructors, wouldn't you say, Christina?
Yes, absolutely. You being one of them.
Daniel, you take the next one.
Yeah, I was going to just make a few comments on this one. So, I like these guesses. I mean, the Buruli ulcer, I was fortunate enough to go to the Buruli Center of Excellence in Ghana a few years back. What a horrible disease. You end up, it's really sort of in contrast to what you see with leishmania, where instead of like this rounded edge, you actually have an undermine. You can actually take a Q-tip and it's just really a gruesome type of wound, which actually, as maybe you later will see, these wounds are pretty gruesome, but it's a particularly characteristic. Interesting enough, it is becoming quite an issue in Australia, so particularly Northern Australia. Vibrio vulnificus. Actually, this is becoming increasingly a problem. I just had a patient in the hospital about a week ago. There was an all-you-could-eat oyster thing going on down in Atlantic City. Apparently, he had 28 oysters and came in with Vibrio vulnificus bacteremia. The mortality is still about 30%. It's really a horrible disease. I almost lost my father to Vibrio vulnificus bacteremia in Paris back when he was in his 70s. And I was on the phone with the doctor, and, it was, I won't say what it was, but I spoke to the doctor and he said, well, you understand, it's already after 2:30. All the doctors have gone home. If your father is still alive tomorrow, we'll have a doctor see him. And then when there was a little bit of a pause, he then followed, you do realize your father's in his 70s, and elderly people like this, they die. Anyway, got him on antibiotics, got him on a flight, got back to the U.S. He's now in his 90s, and he has yet to die. Okay. Jay writes, Dear TWiP team, I suspect this is leishmaniasis. This unfortunate, poorly nourished infant's immune system was overwhelmed by the protozoa. Maria Adelade Gomez in TWiP 230 gives an excellent description of the difficulty treating leishmaniasis, particularly in resource-limited areas. How do we make progress against this neglected tropical disease? I'd love to hear your thoughts about vaccine development, along with therapies that are more effective and easier to administer than those currently used. It seems to me that vaccination may offer some hope. After hearing this case and then listening again to TWiP 230, I made a contribution to Floating Doctors. Their work is so deserving of support. Thank you for another great episode, Jay.
Rafid writes, hello, TWiP team. Thank you again for your great work. I will keep this brief as I am at a medical conference this week. I think the most likely diagnosis is cutaneous leishmaniasis, complicated by bacterial superinfection and sepsis worsened by nutrition. Greetings from sunny Crete and not from rural Quebec this time. Rafid.
That sounds nice. I'd like to go to Crete.
Christina.
John writes, hello, TWiP hosts. Greetings from sunny Mobile, Alabama. In regards to the case of the 1-year-old from Panama, nothing really came to mind until thatched roofs were mentioned. This led me to think of Trypanosoma cruzi by way of Reduvit kissing bug. However, I'm not familiar with chagas causing necrosis. I hope to win the book. Absolutely love the podcast, and I enjoy listening while I'm working in the lab. Best, John.
Daniel.
Michelle and Alexander from the First Vienna Parasitology Passion Club. Right, dear TWiP Panama Somes. I like that. That was clever. This case concerns a young child, they say. They assume this is a human being from northeastern Panama who presents with deep necrotic wounds on his leg. There also apparently it's a boy, which appear infected. What seems to have begun as a minor break in the skin has progressed into a largely necrotic limb by the time of presentation, and the small boy is not the only one in the area with these symptoms. This time, only a few parasitic causes for these symptoms came to mind right away, so we consulted the depths of the World Wide Web. One of our initial thoughts had been cutaneous leishmaniasis, which can be found in Panama. It is also normal for multiple people in one region to experience symptoms. Cutaneous leishmaniasis, however, does not usually involve deeper tissues, and whilst the center of the wounds can become necrotic and infected, the disease is not known to progressively destroy body parts. Nematode infections like dracunculiasis and lymphatic filariasis can cause similar ulcers, but are not endemic to Panama, typically manifest on different body parts, while tungiasis can also cause severe secondary infections and mainly infects the skin of the lower extremities. There are no recent reports of this disease being detected in Panama. It also manifests with a characteristic morphology and should therefore be easy to diagnose. During our search, we discovered information on Cochleo-Maya hominivorax, the screwworm fly, or in other words, a new unlocked fear. Whilst our love for parasitic diseases is undying, this one takes its place on the throne of what we don't need to experience ourselves list. The name translates directly, means human-eating spiral maggot. Cochleo-Maya hominivorax are a significant pest in Panama and other tropical regions in Mesoamerica. These parasitic flies lay their eggs on open wounds of warm-blooded animals, including humans. Once the eggs hatch, the maggots burrow into the flesh, feeding on live tissue, which can lead to severe infections, necrosis, and even death if untreated. The infestation is particularly dangerous in rural areas where access to medical care is limited. Panama has faced outbreaks of screwworm flies, posing a risk to both livestock and people, especially in more remote communities. Treatment for screwworm infections, also known as myiasis, begins with the careful removal of maggots from the affected wound. Following this, the wound must be thoroughly cleansed and disinfected, often requiring antiseptic application. Healthcare providers may prescribe antibiotics to combat any secondary bacterial infections and provide pain management for the patient. In more severe cases, surgical intervention may be necessary to remove necrotic tissue. Additionally, preventive measures such as keeping wounds clean and seeking prompt medical attention for injuries are essential in regions where screwworm infections are common. Thank you for this great case. All the best.
Interesting. John writes, hello, esteemed hosts. Still hoping to win a book and still feel like I'm learning a lot each episode. I began with CDC Travelers Health for the country, and I hope I didn't miss anything starting that way. Malaria, leptospirosis, Chagas, dengue, leishmaniasis, and Zika was whittled down to malaria, Chagas, and leishmaniasis panamanensis. I thought the latter was the only one that matched the description. While non-healing painless lesions are common, they typically heal over with scarring. Exceptions occur in HIV/AIDS patients and with the malnutrition reported. I imagine any immunosuppression can cause worse outcomes, including becoming visceral or spreading as reported in the leg. The scratch threw me off as I saw this typically transmitted by sandfly bite, but if it can't be transmitted from animal reservoir directly, perhaps a sandfly bite on the scratch could result in this and spread either due to immune issues or multiple bites. While geography, microscopy, and culture can be used, NAT is the most used to detect, with the added benefit of species identification, which also helps to know if progression to mucocutaneous is possible. And although the patient expired, this may be of assistance with others nearby that have the same presentations. There's so many treatments. So instead of listing the general purpose of therapies to kill off the parasites along with the local tissue they inhabit, freezing, lasers, heat have all been applied. Local oral and parenteral therapies can be used alone in combination. Some have painful or undesired side effects. Proper hygiene and wound care in healthy individuals may resolve the infection without treatment. and humans are a dead-end host, so preventing the insect vector aids in reducing repeat infections. Secondary bacterial infections should be minded, and I wonder if this infant had one and what the soup was that was referred to. Very unfortunate, and I hope the rest of the local population was able to reach treatment. All right, back to you, Christina.
Friedjof writes, greetings from sunny yet windy Düsseldorf in Germany. Last week I had the pleasure of attending an incredible conference on tropical and travel medicine. In collaboration with the German, Swiss, Austrian, Belgian and Dutch societies for tropical and travel health, we spent 3 days immersed in a vibrant international exchange of ideas and research. The sessions were packed with fascinating scientific discussions and valuable networking opportunities. I was looking forward to maybe meeting Dr. Griffin during the conference, but it turns out he did not attend. Hopefully I'll have a chance to connect with him at the next event. Concerning the case of the 1-year-old, several differentials come to my mind: myiasis, cutaneous leishmaniasis, and non-parasitic Buruli ulcer, and pyoderma gangrenosum. The patient's history, with a pre-existing scratch in the skin developing into one and then several deep wounds, fits best with myiasis, New World screwworm, the botfly. Cutaneous leishmaniasis usually presents as a single lesion in the facial region or as a mucocutaneous form. In patients suffering from malnutrition and infants, the disease may develop more aggressively. Buruli ulcer is more common in sub-Saharan Africa, but a few cases from the Americas are also reported, although none from Central America. Thank you for this amazing podcast. I'm already looking forward to the next TWiP. Yours, Friedjof.
Daniel.
Anne writes, Dear TWiP team, my thoughts for case TWiP episode 243, a 1-year-old infant from Panama is cutaneous leishmaniasis. The disease may be caused by a number of New World Leishmania species. For the infant, the clinical signs described are compatible with diffuse cutaneous leishmaniasis, which I learned from your wonderful text 7th edition has been reported with L. brasiliensis and L. amazonensis infections. If selected, I would love a book for my daughter, currently in her 3rd year of medical school. The clinical case made me particularly grateful that I put my contributions to Parasites Without Borders on an automatic monthly plan. It's probably time to up the monthly amount. I so appreciate all you do, providing medical education to truly underserved communities, contributing to global public health, and supporting science education. Regards, Anne.
Martha writes, Dear TWiP, just saw episode 243. I will be traveling and away from the computer, so no time to wander around on the internet getting sidetracked. I will be brief. Cutaneous leishmaniasis likely due to Leishmanium panamanensis. I look forward to hearing more about the case. Malnutrition was mentioned. With a lesion as large as described, was there also superinfection? Best wishes to you all. Martha, P.S. I already won the book. Christina.
Hawken writes, hoping for a book, greetings. This month's case has me wondering if one of my all-time favorite veterinary parasites is my answer. My instinct initially suggested Leishmania species of some sort as the culprit of this poor child's infection. However, the combination of location, the current outbreak happening throughout Panama, Costa Rica and Nicaragua, and the case line of initially being a scratch of some sort of break in the skin, makes me suspicious of the New World screwworm. While there was no mention of maggots seen in the wound, the offhand comment above made me consider Cochlearia hominivorax. Leishmania, given the former needs, an active opening in the skin to infect, whereas Leishmania, I'm confused here, whereas Leishmania would be the originator of these wounds. Okay.
Yeah, I think the first Leishmania is probably extra, right?
Yes, I was just thinking that confused me. Thank you. Though perhaps I have just been reading too many pro-med reports, if indeed it is C. hominivorax, it might be interesting for Dixon to go into the history of how we eradicated the disease from the USA with irradiated males for the listeners. While at the veterinary parasitologist meeting this summer, the CDC morphological parasitologist had an interesting case where an individual went for plastic surgery to Argentina and managed to come home with them spilling out of the facial bandage he had on the plane ride home. Ooh, thanks for another interesting case. Wishing you well.
Wow. Daniel.
I'm not liking the visual in my head on that.
No.
I mean, we've
Greetings
had
to the
plane
TWiP
rides.
expert quartet. Thanks for another interesting episode and case. Sad to hear this particular case ended so tragically. Using a combination of searches of Google and the PD 7th edition for likely suspects involving parasites causing necrosis, I came back to leishmaniasis as a probable culprit. It appears that Panama is included in areas where sandflies could act as vectors for leishmaniasis, and Dr. Griffin alluded to an abundance of insect life in the area. Regardless of whether I have guessed correctly or not, I look forward to hearing the rest of the story, and hopefully the other cases mentioned were able to be addressed without further loss of life. Thanks again for your efforts and dedication. You are all truly appreciated. David from Maryland.
Ayel writes, Dear Vincent and the sages of the microscopic eukaryotes, greetings from Sydney, Australia, the land of rain and fire. Spring has truly arrived here. It's a beautiful 25°C day, yet only 4 kilometers away, a bushfire is already raging. I'm told summer will be bad. What a catastrophe for the remote community in Panama. Losing what sounds like a bright and energetic 1-year-old in such a horrendous way is truly heartbreaking. My guess for this case is cutaneous leishmaniasis based on the description of the wound and its prevalence in remote jungle regions of Panama. I didn't think a person could die so quickly from leishmaniasis alone. My assumption is that the wound got infected by strep or staph, leading to the necrosis. From previous episodes covering leishmaniasis, I understand it's notoriously difficult to treat, with first-line drugs being different antimony compounds. Essentially, you're hoping to poison the parasite before the antimony poisons the patient. My question is, how are such cases treated in remote environments where patients might only be seen every couple of months? Is there a practical way to manage this in the field? As always, keep making the world a better place. With great admiration, Ayal.
Rod writes, Hi again to all at TWiP. The case presented in the last episode of the unfortunate child with necrotic skin lesions prompted me to listen again to TWiP episode 14. Possibly the skin break was the result of a sandfly bite, genus Leucomia, that infected the child with the protozoan kinetoplastid parasite leishmania, resulting in cutaneous leishmaniasis, which spread to other nearby regions of the child's leg. Possibly these lesions could have subsequently become the site of the bacterial infection. Sorry to hear that the child did not survive. Thanks again for all that you do. Regards. Rod in North Portugal.
Anthony writes, Hello all, a very mysterious and scary case indeed. The only thing that comes to my mind is something like mycetoma, that then got a secondary infection with something flesh-eating like Vibrio or MRSA. Perhaps anthrax or a really venomous animal bite sting would also cause symptoms directly. Anthony.
Christian writes, Dear TWiP team, greetings from Basel, where a mild autumn is inbound. This case of the 1-year-old is not offering too many details. But going by the ulcerating, necrotizing wounds and the fact that many other people were also affected, I would suspect an outbreak of leishmaniasis. The species could be L. viania panamensis, which is the predominant form, though L. viania brasiliensis and L. infantum have been reported. Parasite itself, being transmitted by sandflies, would therefore be able to infect many people. The skin ulcers caused by the parasite can grow to grotesque sizes, and in a 1-year-old child could cause substantial soft tissue damage. Additionally, bacterial superinfection can happen and would complicate the infection. Treatment is guided by species, so PCR would identify the species and location, number of lesions, and whether mucosal tissue, ENT inspection recommended, is affected. Looking forward to see what the diagnosis was. Christina.
Tiago writes, Hello from Portugal. My guess is screwworm, larvae of flies that invade living tissues around the wound. An alternative could be leishmania, but usually is not limb-threatening. Your follower, Tiago. Shall I do the next one too?
Sure.
That was very short.
Sure.
Benita writes, my name is Benita Michael, and I'm currently in my second year of residency in pediatric infectious diseases in Mexico City. I recently discovered TWiP. First, I would like to thank you and congratulate you for the in-depth and entertaining content, especially the earlier episodes, which serve as valuable learning tools when one begins to study specific parasitic diseases. Regarding the case of the infant from Panama with necrotic wounds, I must admit I was baffled. This is not a typical manifestation of parasitic diseases, especially not fatal ones. I have considered the following differential diagnoses. First, cutaneous leishmaniasis. Skin ulcers are the main manifestation of this infection, although typically only one of a few ulcers or a few ulcers are present, and they usually do not become necrotic. Some cases of disseminated leishmaniasis can present with multiple ulcers. It is defined as the presence of 10 or more polymorphic cutaneous lesions in more than 2 parts of the body. Most cases are caused by Leishmania, Viania brasiliensis. Children are more susceptible to this form of the disease than adults. It is thought to occur in patients with a more pronounced Th1 response in tissues, meaning few parasites are found in situ. The diagnosis is challenging, primarily relying on the characteristics of the lesions. A positive Montenegro test is usually required. The lesions include multiple types at once, such as papules, acneiform papules, and ulcers. Necrotic lesions are not typical features, and the absence of other body parts being involved should raise suspicion of other infections, mainly bacterial. My second guess is cutaneous amoebiasis, caused by Entamoeba histolytica. This is an unusual presentation. The absence of dysentery and the occurrence of other cases makes it even less likely. My third and final guess is cutaneous myiasis. This is a neglected disease for which little information is available. It is more common in other mammals such as cattle and dogs. Humans living in poor hygienic conditions are susceptible, and the primary species of concern is Cochlearia hominovorax, the New World screwworm. Obviously, the diagnosis relies on the observation of the larvae in the ulcers. I must say it was a true challenge. Finally, I would like to join you in wishing President Carter a happy 100th birthday in October 1st. What an extraordinary legacy. I'm really excited to hear the answer in the next episode. Greetings to all from Mexico. Best regards, Benito.
All right.
Yeah, President Carter just turned 100.
I know, amazing, isn't it?
Yeah, I had the pleasure of meeting President Carter a number of years back when I apparently upset my wife because I did the grandfather, the son-in-law handshake, where like you hold the hand and then you take him by the elbow and you assess the muscle mass and the lymph nodes and what a tremendous man.
So Daniel.
Well, I think we get 2 more guesses and then Ben tells us what's going on. I think it's reasonable to say that somewhere buried in there in our emails, not so much buried maybe, is the right answer.
Sorry, I'm laughing.
Yeah. So should we let Christina, let's let you go first.
Yes.
What was sort of the first little twist? Everyone seemed to assume this was a child.
Well, I didn't think that was a human child. I thought it must be an other animal because the way you described it, you were very non-committal in saying, usually you say this is a little girl or, the mother presented history. And I kind of thought, no, that it's probably not a child. So I thought it's maybe a small mammal, maybe a dog, maybe a cat, a goat. I don't know, just some kind of companion animal, maybe, shall we say, of which there are quite a few present. So that was the first thing I thought. And then the other thing that popped into my head was a really horrendous presentation. Actually, it was an entire workshop I went to in 2018 in Saskatoon at the World One Health Congress, and it was all about the eradication of the New World screwworm. And the clinical picture that you described, although it wasn't really in great big detail, I thought that, I don't know, that just brought those horrendous PowerPoint slides back into the forefront of my mind. And I did a little bit of Googling, and I was actually surprised because we teach myiasis on our DTMH course, but, that was maybe isolated infections, like, a person might have one or two or a few of those worms. Not worms. What am I talking about? I'm too tired. Larvae, maggots.
Yeah, maggots.
There we are,
maggots.
So, and actually, when I saw that presentation, it was so shocking to see how badly affected those animals were. They were particularly deer. They were talking about deer in Florida in particular. And it was just horrendous to see how quickly they also went downhill and essentially died. So that is my guess.
All right. So
and I think
in an animal, maybe a dog, I guess.
Yeah, I don't know, just something smallish. If there's plenty, probably not cattle. Well, it could be cattle. I don't know. Could be any animal, really. Deer. I didn't think, I don't think cutaneous leishmaniasis, even in a malnourished child, probably wouldn't cause that severe a disease. And in many children, and also the food described, I don't think, I've not fed that to my infants. I didn't fed protein-rich soup to my infants. They've kind of had more of a milky, vegetable puree kind of diet at this age. So that's the other thing that made me think it maybe is an animal. So,
Vincent, we don't want to leave you out. What are you thinking? Do we ever present infections of animals? Have we ever done that?
We have once before, of course, a penguin at the Bronx Zoo, which you also described. It was a 5-year-old penguin or something.
I remember that.
A 5-year-old who was a what is it, raw fish, exclusively raw fish diet?
Yeah, eats mostly raw fish. But when you told me after the episode why do you assume it's a child, then it was even harder for me because I don't know anything about parasite infections of non-human animals. So if it were a human, I'd say leishmaniasis or myiasis. I think those are two good ones. And maybe that can happen in, for the leg to get necrotic and multiple lesions, it would have to be a good sized leg, right? A dog or a cat or something that's in multiple species, in multiple numbers around the site. So I'm going to just say leishmaniasis or myiasis. All right, Daniel.
All right. Well, since this case is from Benjamin LaBrot, let's Ben. What was this?
So first, I really do have to say, this case obviously had relatively limited detail. There were definitely a couple of Hail Mary desperation shots among the emails that came in, but overall, I really found a lot of the guesses, even the ones that weren't correct, to be extremely well thought out, and not bad guesses. In this case, a couple of people actually managed to get it right. This was a case of New World screwworm in a 1-year-old adolescent, which was in fact a canine. In one of the indigenous communities served by our organization. The picture certainly would have given it away because the picture of this deep tunneling wound, the leg just looks like Swiss cheese if meat were Swiss cheese. And there are a bunch of eggs perched, kind of on the edge of the wound. And there's actually one of those characteristic flies actually visiting the wound. Of course, Cochleomya hominovorax does, of course, mean literally people eater. And because this fly is sort of, metallic blue and green, sometimes a little bit purple, I would like to point out that this is, in fact, quite literally a flying purple people eater. So that apparently actually does exist.
It's a thing.
So we did, in fact, have to euthanize the dog. This case was seen by the veterinary arm of our medical organization. It was actually a really good example of why a veterinary arm is useful, especially in remote rural medicine, because there are a lot of, outside of all of the ethical considerations and animal suffering and livestock being in better condition, and that supports communities, there are a lot of horrific zoonoses, including New World screwworm. And we did find other patients. This was also really interesting. A lot of people didn't think of this because And I heard someone say that this was, there was an age barrier, that if you were under about 45, you were unlikely to have ever heard of this. But if you were older, you were more likely to have heard of screwworm, because screwworm was a really horrendous problem in the cattle industry in the southern United States and the southwestern United States, especially through the 50s. Up to about 20 to 80% of livestock or animals that are infected with screwworm will die. Unique to a lot of the myiasis that exist, such as other maggots that will eat dead flesh. New World screwworm fly maggots eat live tissue, and they have a voracious appetite for eating live tissue. And typically, within a week or two, deer, domestic animals, and sometimes even people will be dead from secondary infection and sepsis. You did, Christina, point out some of the stuff you saw with deer. One of the characteristics for this fly is that it's deeply attracted to the smell of wounds. And one of the things that it's often attracted to are the umbilical cords of newborns, in particular of newborn deer. And so will infect their bellies. And fawns that are infected, you might often see them kind of trying to stand in water up to their bellies, for some kind of cooling effect. This has been held at bay by an invisible worm wall for many, many years. This was a huge problem, costing many millions of dollars to the cattle industry in the 50s. And in the 50s, an enterprising scientist figured out that if you irradiated these flies so that they would be sterile, fortunately for us, there are some characteristics of the fly that really facilitate using sterile insect, to control them. The females only breed once. They can actually lay multiple clutches of eggs. A female fly will land on a wound or the edge of a wound, even something as small as a tick bite. They will also land in mucous membranes, so the nasal cavity, the vagina, vulva. Really horrendous. And they will lay their eggs in the wound, usually a couple hundred at a time, but they can lay multiple clutches. So they will mate only once, but they can lay up to about 3,000 eggs. And so it's not uncommon to find very massive infestations. So because the males are very sexually aggressive and the females only mate once, this really was a great candidate for raising sterile insects and interrupting transmission by releasing sterile insects to breed and produce non-viable offspring. So first we did this in the US, and by 1966, screwworm had been eradicated from the US. They built a facility in southern Texas to rear screwworm larvae and try and continue keeping that pressure on along the Mexican border until they realized, this is a 2,000-mile long border. This is really difficult. Why don't we push that further south to the Isthmus of, and I can never pronounce it correctly, the narrowest part of Mexico, just beyond the border of Chiapas, south here to the border of Chiapas, is only about 120 miles across, I think. And so, in partnership with Mexico, we embarked on a really aggressive eradication program, working further and further south. And of course, once they got to that 120-mile border, they decided, why stop there? What if we keep pushing south all the way to Panama? That's even narrower. And so the elimination programs continued. These were really hardcore elimination programs. In Guatemala, I think they started in 87, finished in 94. Belize in 89, finished in 94. El Salvador in 95, finished in 96. I mean, they just marched south. And it was finally in Panama, they embarked in 1997 upon their eradication program. And by 2006, it was declared eradicated from Panama. And that same year, they built a sterile larva production facility near the Darien in the southern region of Panama. And since then, have essentially created an ongoing worm wall. This program essentially produces up to like 20 million viable larvae every year. And they airdrop them all over that region. They airdrop the larva land on the ground, the larva hatch. And of course, once they hatch, they mate with wild females and significantly interrupt transmission. In Colombia, unfortunately, it's still endemic. And Panama actually developed permission with Colombia to make these flights over Colombian airspace, dropping these all along the Darien region on both sides of the border. This was a pretty expensive program. Throughout Central America, it probably cost about $200 million. But But if you think that's expensive, the anticipated savings from that being eradicated just in the U.S. alone today would be up around $1 billion a year for the livestock industry. So this is something that has had a lot of really ongoing surveillance and pressure. It's pretty interesting to do these flights. They'll release about 60 million sterile flies weekly in Costa Rica when they were trying to do the eradication program. They dropped them at 6,000 feet. You try to get about 3,000 per square nautical mile. I mean, this is really, really aggressive. Unfortunately, as with most conditions, it's very hard to maintain political and social and economic will to really keep these kinds of aggressive surveillance programs in place, especially when you haven't seen one for decades. And especially as we've had so much more migration through the Darien Gap, as traditional routes into the U.S. have closed, very large numbers of immigrants from other parts of the world come to northern South America and walk from Colombia through the Darien Gap, which is one of the worst places on earth, I'm sorry to say. They walk through the Darien Gap and then all the way up through Central America. There have, since this screwworm has kind of been popping up again in parts of Central America, actually been a couple of human fatalities. And this is something we really want to not occur, because prior to eradication, like in Nicaragua, in El Salvador, I think there were 530 known cases between 1990 and 1992 alone, and quite a number of those people lost limbs, were horribly disfigured. In Nicaragua, there were at least 138 cases, 70 of which were children, and 3 of them died. Others, lost body parts. So this is a really horrendous disease, and it's fast. Once the eggs are laid, within about 12 hours, I think, the eggs will hatch and the larvae start burrowing. By day 3, you've got great big maggots that are clearly visible, tunneling their way around. Once they mature, then, of course, they drop out onto the ground as pupa and then become flies and continue their horrible, horrible way. So this is also a really great example of the utility of kind of rural frontline healthcare workers in being able to make early diagnoses and early recognition of these conditions. This was similar to when chikungunya arrived in Central America. It did not arrive in Panama first. It arrived north of Panama and south of Panama. And we just sat there knowing it was coming and did identify 2 cases, actually on the same island, I just realized, where the same community where the screwworm was just discovered about 6 months before it was recognized in Panama. So a very excellent guess, Christina. That was some really Sherlock Holmesian level deduction. I had us off to the folks who wrote in and also successfully diagnosed it based on extremely limited information.
So Ben, in this area, were there any human cases at the same time?
Not that we know of yet. But of course, one of the difficulties is, reportability. A huge number of these kinds of things are going to occur in extremely remote rural settings, in marginalized populations who are very unlikely to seek kind of healthcare from traditional sources. And I guess I should say by traditional, I mean traditional Western medical sources until, the very last minute. So fortunately for us, they'll probably present early, but it's still a 10,000 square mile area that we cover of jungle and mountains and mangrove. So
was that quite recent, Ben?
This was, I think, about 2 months ago.
Okay. It's really interesting because I'm just looking at the self-declaration of eradication or elimination that was submitted to the World Organization for Animal Health by Panama. And actually, I think the surveillance is pretty poor. I'm looking at a table here. So there's just been, because he mentioned it had been eradicated in 2006, but actually, if you look at the reported cases, there seem to be still quite a lot, all the way up to 2019 when that report was finished, primarily in domestic animals, very few in, wild animals, but I presume that is just because they haven't been detected or no one's looked. And so I think there was 1,868 reported in domestic animals in total in that period, and 165 in people. I think that probably reflects pure surveillance more than anything.
It could be. I know that during the period of surveillance, there was a fairly large number of surveillance workers working along that kind of worm wall region in the Darien. We had people traveling by boat, by motorcycle, by horse and on foot, inspecting ranches, inspecting every cattle shipment was inspected. And so you would find them in cattle coming across, so some of those cases may have been related to not kind of newly endemic cases, but imported cases that were recognized. I'm not sure. But again, the HIV office for the entire state where is, on paper records entirely. And so, the reporting is, fraught with all kinds of significant challenges. What agencies may not want to report, because that might show an indication that what they're responsible for has failed. And so sometimes problems can also go unreported for, much longer than they should.
Mm.
So why did you, how was this dog detected initially? Was it someone's pet and they reported it or what?
Yeah, it was someone's pet. Our veterinary team typically accompanies our medical team. And while the human medical team are seeing people, the veterinary team are doing spay and neuter and checking the livestock and taking care of people's domestic animals. Is a relatively new concept in that population to consider like healthcare for their animals, especially, which made sense when there was no healthcare for them. Well, why would they even think of healthcare for their animals? So it's nice that we have established that different kind of culture, because otherwise we may never have heard about this. So I was really relieved, that someone managed to bring this dog to us. The veterinarians were initially looking at potentially amputating the leg, but the dog was already so sick and showing signs of sepsis that the dog was euthanized.
And then how were the other infected dogs detected?
Once we realized what had happened, then the veterinary team went to some of the community leaders and some of the folks from neighboring communities who had come to that community and said, hey, if you've got any animals or any people with this, you've got to let us know. You've got to bring them in. And we had to explain, most of the people living there had not seen these because, not there, there's plenty of older people, but the vast majority of the population are certainly under 40. And so it was some of the older folks had kind of remembered this and, people thought maybe it was bot fly, which our patients aren't as worried about because that's, of course, a much more localized lesion and then the bot fly leaves, so we had to really embark on an educational campaign to let people know that this was different and that this was something that was not just going to be local, but potentially region-wide, continent-wide, and something that we really needed to know about.
Were the other dogs treated in any way?
The other dogs, I know they pulled a couple of, collections of the worms out of some of the dogs, and some of the dogs I think were all right. They were earlier stages. I have to check. I'm not sure whether any of the others were put down.
What about prevention? What would you do to prevent insecticide, cow DEET and stuff?
Well, you can use, that's not as practical for our patients who simply can't afford that.
No, that's
we've
true,
got living on, $50 a month. A lot of these are indigenous subsistence villages. But certainly, and I think as that case we alluded to of the person who went to Argentina and came back thinking that they were going to be a little more beautiful from their plastic surgery with maggots falling out of their face on the airplane. Oh, God, it's horrible. One of the things is to cover wounds. That's really, really important. It's the smell of the open wound, that really attracts them. So if you've got open wounds, you cover them, you put stuff over them. And certainly the flies are quite distinct. They have these big, bright orange eyes. They're about twice the size of a normal housefly. And they've got these bright orange eyes and then these metallic blue, kind of vertical or longitudinal striping. So at least they are visually identifiable, but otherwise any rapidly enlarging wound, especially a tunneling wound, would certainly you'd want to present very quickly because even in humans, if this is untreated, especially in the settings where this is occurring, the likelihood of secondary infection and sepsis becomes almost astronomically high.
So are there any efforts now to try and re-eradicate in this region with the sterile males?
Yeah, so the Panamanian government responded to this epidemic by increasing the production of sterile pupa from 20 million to 92 million per week. They've increased their aerial dispersion. I think they're doing 15 weekly airplane flights and 40 ground releases in Nicaragua as well, averaging a dispersion of something like 54 million sterile flies a week. They've increased their field surveillance. They're visiting farms. They've increased animal movement checkpoints. This can be difficult, though, because there are a lot of people who will use jungle trails to move their cattle around checkpoints, especially if they're worried about checkpoints potentially eliciting kind of bribes or turning their cattle away, which would be economically catastrophic for the folks trying to move their cattle. But as of now, the screwworm epidemic is still quite viable. This still really represents a threat to human and animal health.
Wow, what a remarkable story. Tell us a little bit about yourself, Ben. Where are you from?
Should we give away a book first?
I forgot. Sorry.
Give away a book.
Yeah, we have to give away a book. We had.
We're going to learn all about you, Ben.
Yes. Sorry. We.
Christina, can you give us a drum roll because Dixon is off traveling the world?
I'm actually not sure how to do a drum roll. What does he do?
Yeah, that's it.
Yeah, you did it.
When do I start?
Number 6. We picked number 6. That is Hawken. Hawken won a book.
He's been wanting
he said,
a book. Yeah.
hoping for a book. There you go, Hawken. Just send us your address. You're in Athens, Georgia, I believe. Send us your address to TWiP at microbe.tv within the subject line book winner, and we will send a signed book to you. So good for you. Congratulations. Okay, back to you, Ben. Tell us where you're from, where you were educated, college, medical school, and how you ended up making this amazing organization.
I had an unusual path. I'm from Southern California originally. I studied marine biology and history for my undergrad, always with the intention of going to medical school. But fortunately, marine biology covers all that organic chemistry and everything else. So did marine biology. So I had worked as a marine biologist all through high school and college. And then went on to study medicine at the Royal College of Surgeons in Ireland, which was particularly useful. The emphasis there was very heavily on classical clinical diagnostics and clinical medicine, which was exactly the kind of medicine that I was most interested in. I wanted to be a primary care physician. I stuck around out there as a hospitalist for a few years, and I always thought I would practice medicine in the U.S., but on my way back to the U.S., I kind of got sidetracked in Africa, Haiti, Honduras, Panama. I had been traveling in Africa and had my first sidewalk consultation where there was no sidewalk in a Maasai village. Someone was, "Oh, you're a doctor. Hey, well, you're here. Can you take a look at this thing?" And my experience that day, and the 7 hours worth of patients that I saw afterwards really told me, this is what I wanted. This is it. This is what I'm going to do. It's the blinding flash on the way to Damascus, right? So I ended up, if I had come from a pilot family, it might have been an organization called Flying Doctors. It's just as well that I'm not, because that's already taken. But I come from a maritime background, and I thought a lot about, both the barrier that water creates and the opportunity that it creates for reaching a lot of communities that are simply inaccessible any other way. And so we managed to find some folks to give us an old 76-foot, 115-ton ship of theirs that had actually been underwater. And about 14 of us spent a year sleeping on the floor of a 3-bedroom house in Florida, and we rebuilt the ship and loaded it with supplies and had no money at all, not even any personal money. And then the earthquake in Haiti hit in 2010. And we sailed for Haiti totally penniless, and worked in Haiti during the earthquake, then went to Honduras for about a year, then went back to Haiti during the cholera epidemic, then had been invited to Panama. And by day 2 in Haiti, we knew that our original plan of doing kind of brigade medicine in many locations should shift to trying to establish ongoing permanent healthcare services. We were not going to solve problems in 3 days. That a short-term brigade could really play a big role in meeting acute health needs, but we were seeing people with long-term needs and long-term infrastructural kind of problems. So Panama, we arrived, we found this big archipelago, water access only, 10,000 square miles of jungle, 180,000 indigenous folks in little tiny villages scattered through this region, and decided we put our first permanent rural healthcare service there. And so for the last 13 years, we've been operating 52 weeks a year, a rural healthcare service from a central base. Our team goes out every week to a network of communities. We go out to the community, do healthcare, come back, go out to the community, do healthcare, come back to a much farther community, go out and stay there for a few days, come back. And we repeat these visits to the communities on a 3-month cycle. So we get to all of our target communities every 90 days. And that's really allowed us two things. We've been able to take a longitudinal approach to trying to tackle some of these disease problems. And it's also created a unique relationship with this very elusive, otherwise elusive population that really has allowed us to do and accomplish so much more than we would have thought possible. As in the pandemic, when it was time for vaccines to come out, our indigenous patients, they have mostly no electricity, no running water. They're very remote rural villages, but the radio reaches out there. So they're listening to the radio, and they were hearing on the radio all the same stuff about the vaccine that people saw on Facebook here. And so they came to us, much like say, well, I want to talk to my GP before I get the shot. So they came to us and said, we have questions. We said, no problem. We're happy to answer. And held this great big charla, just called a chat. Everyone's like 8 feet apart, masked, and we give a very short presentation. And our patients, said, well, will it sterilize me? Will it make me sick? Will it give me COVID? Will it make me buy Microsoft stock? They're all the same questions. And we answered them as best we could. And at the end, they went, all right. And I think we're going to get the vaccination. We were like, great. And I have to say, I really had to contrast that with a lot of my experience in the US at that time, where a lot of American patients were having the same kinds of conversations with their GPs. And then finishing the conversation with, yes, but I saw on Facebook that my friend's sister's husband's former roommate got the vaccination and both of his testicles fell off. And so I'm not going to get the shot. And you're just like, it really spoke to the importance of that doctor-patient relationship. Yeah. And it's one of the things I've enjoyed most about working in that setting. So,
and the boat still exists?
So when we got to Panama, we traded in that ship for big dugout canoes. We travel in these 20, 30, 40, I think our longest canoe is 52 feet.
The Southern Cross is now back underwater. Just to complete
the
cycle. Last I was there, you could see a little bit of it.
And it won't go all the way down. We sold the boat to somebody else who unfortunately let it go aground and it broke up. But it won't go all the way under. Every time I drive to our base, I have to drive by it. It would be like burying a beloved family member and having part of their arm and head sticking out of the grave. Yeah.
Oh my gosh. So now all of the operations are in this area of Panama, right?
Yeah, it's a pretty large work area. And, we do see a really wide variety of these exotic tropical, we see a lot of leishmaniasis. Mm-hmm. Everybody had worms, but that region has learned to fear our anti-helminthic power because we have distributed so much albendazole and ivermectin in that region that I definitely see a lot fewer swollen bellies, which is nice. We do see Zika, there's dengue. There's no malaria in our region, which is a bit of a blessing. So it's at least one thing. But what we also, of course, see as some of the biggest problems are things like diabetes, that really are a growing problem, and hypertension and heart disease. As the villages do gain any kind of economic advancement at all, just because you have more money doesn't mean you run out and buy kale, even if it's there. You might buy cheap sugary snacks, things that are unhealthy. And so we're really trying to really take this generational approach to trying to tackle these conditions as they're developing, rather than waiting until they're endemic in the population and then trying to tackle it then.
Do you go there a lot yourself? Because now I see you're traveling.
So it used to be, that was a 24/7 job in the early days. Someone's here with a bloody rag wrapped around their arm. Okay, that's me. The toilet's not working. Okay, that's me. We need $10,000 for a medication order by tomorrow. Okay, that's me. Now, none of those things are me unless I wanted them to be. So I go down now about every 6 to 8 weeks, for a week, mostly to kind of marvel at what the team are doing. I never wanted to be a personality cult. If something happens to me, I wanted it to do very well on its own. And, when I really kind of start trying to total up the team's accomplishments, it just staggers me, what they've managed to achieve and what they keep achieving. The median survival from diagnosis to death for HIV patients in our region is 6 months. The median age of death is 26 years old. 20% of the new HIV infections are in girls under 15. On the other, you've got in the U.S., we're going to eliminate HIV by 2030. It's really, really difficult sometimes for me to look at these really ambitious goals and also look at the reality for a lot of our patients. So, our goal would be to work ourselves out of a job. If we could work ourselves out of a job there, that would be great. If we could build enough capacity. Unfortunately, even Los Angeles still which has plenty of resources and lots of education, still needs hospitals. So I doubt that we'll be worked out of a job there anytime soon. But that is an important North Star. That when we encounter these problems, we need to try and we'll put a Band-Aid on it and then try and figure out how to not have to keep providing Band-Aids in future.
So how many staff do you have down there and what are they?
At any given time, I probably have about 20 staff members and between 15 and 30 volunteers. Staff members, there'll be a half a dozen or so medical providers on the medical team. I have a veterinary team. We have dental. We have health education. And then, of course, our volunteer coordinators and other logistical staff, our captains. And then our volunteers, really, they could be non-medical or pre-medical, or they could be a retired physician whose license is still active, or anywhere in between. We've had about 7,000 volunteers from 59 countries. The youngest was 4 months old. He was with us for 10 months on the hip of his mom. The oldest has been 83. And we very early discovered there should be two outputs for an organization like ours. Obviously, improved patient outcomes and capacity where we're working. And the other output should be better doctors who leave our program. However good you were as a physician or however motivated you were in your humanitarian ideals, our goal and how we've curated our program is that you leave better at both. And so we really, we often entice people with the prospect of seeing these exotic, unusual conditions in an exotic location. And that's, of course, very true. But there's also a certain beauty to being able to do house calls. I have not had in 10 years a single U.S. resident or younger who has ever done a single house call. By the time they're done with us, they've certainly done some. And it's really, until you have context for things, it's difficult to abstractly understand their value. That first 10-second look around the inside of someone's home where right away, oh, this seems like they're coping pretty well, or I think this family is going to need a little bit more support, things like, or a consult that lasts more than 15 minutes. Things of that nature. So there's a lot of, in some ways, it's like practicing 19th century country rural medicine, but portable ultrasound and, portable cardiac and all these things come out of your bag. So it's a nice mix of that, the best of old medicine with, some of the most advanced, kind of tools that newer medicine offers.
So Daniel, you go there now and then, right?
I was looking back. Apparently, October 2017 was the first time I went. So so 7 years ago. Yeah. I actually went to the same community that Daisy. So my daughter Daisy has actually volunteered, and she's finishing up her nursing, and then she may come for a 3-month stint. So
that would be awesome.
Yeah, which would actually maybe coincide with March when we're doing our continuing medical education, right? So
yeah, I mean, it would be. I couldn't not give a shameless plug for our continuing medical education course. It is about 43. PRA, AMA Category 1 credits, which is not bad, for a 1-week course. We embed you with our team. Dr. Griffin, of course, he's one of our parasite lecturers, giving everyone nightmare fuel before we actually deploy out into the jungle. We have really great instructors. And again, it's a lot of, it's how to do medicine in that kind of setting, but there's a lot of wilderness medicine and, disaster medicine, but there's very little. What do you do when you have a patient, with a history of, a heart attack 2 years ago and who's having some chest pain, on exertion in these kinds of, what do you tell them? I mean, what do you tell a type 2 diabetic patient? Eat less starch, they'll die of starvation. So understanding we talk about patient-centered medicine a lot, but this kind of medicine really forces you to think about not just giving good advice, because doctors are really good at giving good advice, but not all good advice is helpful. And there is a difference between giving good advice, like get some exercise and make sure to get good sleep, and you should take some days off work. That might be good advice, but helpful advice is what is actually practical for that patient. And that is a very, very useful skill, especially for modern physicians in training who do spend a lot of time learning the guidelines and algorithms, to really remember when it's necessary to depart from those to create a care plan that will work for a particular patient. And if you can do it in that challenging setting, then, at home it should be even easier.
Yeah, no, it's a great CME experience because, we do the lectures, but you actually go out to these communities, you're taking care of patients with one of us, proctoring right there. It's, because otherwise, you take these courses, you just get the lecture. Here you actually get to see patients, with someone who's done this for years and years. And you get to ask, what am I seeing, and kind of work through it. So it's a really great hands-on, and you're in one of the most spectacular places in the world. I mean, this is like what I imagine the Galapagos must have been before they were inundated with tourists. In the mornings, the dolphins are gathering before they go out for the day hunt. The sky is just beautiful. There's the bioluminescence in the water. I have to say, it's a spectacular part of the world.
It is. And what medical clinic elsewhere offers the opportunity when you come back hot and sweaty at the end of a day practicing medicine to jump off the dock into 83-degree Caribbean water and float with your comrades, kind of hashing out the day and, kind of interacting with physicians and healthcare workers from all over the world. I mean, just the knowledge exchange, I think, that occurs between the volunteers is so extraordinary. I mean, you should see what the U.S. residents, how they react when they hear from the UK residents going, well, I actually just took a 6-month leave out of my, after SHO to go and do. They're like, wait, you took out 6 months and you didn't?
They're still going to let you be a doctor.
Yeah. So for people who are interested in that, I do really recommend, we have the March course coming up. It's going to be really fun. Go to Remote Care Education and you can register for that course. Otherwise, if you'd like to just come and volunteer with us, that's still an amazing learning opportunity, and that can be done at floatingdoctors.com.
Do you have any plans to go anywhere else, or are you going to stay there because you need a lot of time there?
Just prior to the pandemic, we had begun looking at Iquitos, the gateway to the Peruvian Amazon, a similar setting, an area with kind of infrastructure opening up onto a huge jungle area networked by water, indigenous communities with poor access, marginalized populations. Pandemic pretty much, shot that whole thing down. And then we, of course, were rebuilding our program afterwards. But we're now kind of looking at that again, especially with some of the kind of funding sources that we've encountered more recently. We're really looking at potentially planting that flag elsewhere, because this model certainly, would have viability in many other locations. So I would love to see our flag flying a lot of different places before I die. So
I'm going to try to convince Ben to join us over in some of the parts of Africa, which I'm sure he would love. So when I leave for Tanzania at the end of next month, I'll be thinking about, locations.
Oh, killing me. Oh, it's where it all starts for me. Oh, my heart.
So Ben, if people want to support your organization, where should they go?
Well, at floatingdoctors.com, we do have a donation portal, of course. It's 501c3, tax deductible. And I will say this, we spent so many years impoverished and hand to mouth. I was unpaid for 5 years, wearing hand-me-down clothing left behind by volunteers. And after we developed economic stability, that poverty mentality we had still existed. So I'm very proud of how what we do with the funds we raise. Our funds really go to try to tackle the problem. We really, what some larger organizations whose funding often goes out into mailings and things of that nature, that's just not us. We're about trying to work ourselves out of a job as hard as we can. And any support that comes to us really gets put to use.
Great story. Thank you, Ben.
Thank you. That was really interesting. Do you need any kind of boring old middle-aged female university lecturers who could come and volunteer?
Always. One beautiful thing about traveling by boat is there are 1 or 2 communities where it's 5, 6, 7 hour trek in boots up through in rubber boots up through the mud, but not many. Most of our communities we ride there and then get out and we're actually at the community. So we've had a lot of people who have more limited mobility. We've had we encourage people to bring their families. Panama has good security, so if people wanted to do this as a family, we have a million things for non-medical people to do, not just to keep them busy, but to actually really get involved while they're there. And it's a wonderful experience for a family to have together. I know Daniel, of course, has come with his daughter. Whenever my dad can come and practice with us, that's always get to practice alongside my old man. Always a special experience. So definitely something really applicable for almost anyone. And if someone is ever thinking about doing this kind of work, I will say the title of our CME course is something like Orientation to International Aid Work. But on the first day, I tell them the real title is How to Travel to Foreign and Exotic Places and Help People Without Wrecking Their Lives Through Ignorance. Because a lot of people like to do this kind of work, but there's not really very much training for it. And so a lot of people go sometimes with good intentions, and especially in Haiti. I think Haiti is really where we decided we had to come up with something like this, because we saw a lot of effort and really well-meant effort, sometimes wreck people's lives, without people ever finding out.
Christina, go for it.
Yeah, I'm just thinking, looking at my calendar just now. I'll go to the website, and I've actually also put the website link onto our show notes so that I can maybe go into.
That's great. Yeah, website. And we're in the middle of our fundraiser, right, for Floating Doctors.
That's right. It's on now.
Yeah, parasiteswithoutborders.com, and we'll double. We're going to get up to $20,000 to give to Floating Doctors.
That's fantastic. Yeah, at Parasites Without Borders, I mean, I feel like, that just, all you have to know about Dr. Griffin is, that he gives away his medical textbook for free on his website. I don't know any other professors who do that. And has Parasites Without Borders. That really tells you everything. And the CME course will be the week of March 17th, Christina, if you want to look at your calendar. So if you want to come that week, please feel welcome. It'll be fun.
I might email you if that's okay.
Yeah, absolutely.
Sure.
Anyone who's interested, well, I don't mind at all. You can email me at ben@floatingdoctors.com. It's floating, like floating in water, and doctors all spelled out, a bunch of doctors.com.
Cool. Yeah, it's already on my calendar, so I'll be there.
All right.
Oh, so it could be a big old catch up.
Daniel, do you have a new case for us?
Yeah, I had like 3 cases that were competing, and I actually forgot that I had already put this one in. So we'll do this one, but I've got a couple others, whatever you say about that, on the shelf, I guess. I don't know. So this is a man in his early 20s. He comes in reporting pain when he urinates or ejaculates. Bit of a clue there, right, guys? So he reports that he is sexually active. He does confide that he's been in a relationship with a woman, but he had a sexual encounter outside this relationship about 2 weeks prior when they were on a break, as he says. He did not wear protection. He feels like he needs to urinate more often and describes thin white discharge from the penis. He reports that he has no history of any sexually transmitted infections, really had no medical issues prior to this.
So, Daniel, what was the nature of this outside relationship? Was it a man or a woman?
He had vaginal, receptive. The woman was receptive.
Yes.
Yeah. So he had vaginal intercourse with a woman.
Okay. And up until this point, he's not HIV positive, right?
So he up until this point, he has, no prior. He's been healthy otherwise. This was a one night. He met this woman, and that was it.
Was it a Friday night, Daniel?
That's all it takes.
We're recording on a Friday. So I'm wearing my clap bow tie. I was relating the history of, so this is not gonorrhea, by the way, but gonorrhea has the nickname of the clap, which is related actually to the treatment, which was to take I believe it was a King James version, and then clap it on the affected body part to effect cure of the gonorrhea, which I don't know if it actually does much for that infection, but it may prevent future infections or reporting future infections to that provider. Okay.
So is this a local case, or was this somewhere else?
Yeah, this was actually local. This was here in New York that I saw this gentleman.
Okay. So that does narrow it down a little bit. If it's not, it's not somewhere in a remote tropical jungle setting. That does.
No, we were
that does
actually
really-
able to do testing right there at point of care. Looking through a microscope, I was able to immediately make a diagnosis, if that's helpful.
Oh, excellent.
Cool.
Yes, that is helpful.
Yeah.
All right. You can send your guesses to TWiP@microbe.tv. Put in the subject line TWiP 245 case. That's today's episode. Okay. October 28th, TWiP@microbe.tv. In the subject line TWiP 245 case. And it's about a month off. We will have our episode. I think we're recording next on a clinical case November 1st. So that's why we want them in a few days ahead of time. All right, that is TWiP 245. You can find the show notes at microbe.tv/TWiP if you have your guesses. As I said, TWiP@microbe.tv. If you enjoy these programs, these science programs, we'd love to have your support. Microbe TV is a 501c3 nonprofit. Your donations in the U.S. anyway are federal U.S. tax deductible. Go to microbe.tv/contribute. Our guest today, Ben LaBrot, founder of Floating Doctors. Thanks for joining us, Ben.
Thanks so much for having me. That was fun, as always.
Daniel Griffin's at Columbia University Irving Medical Center, parasiteswithoutborders.com. Thanks, Daniel.
Oh, thank you. And everyone be safe.
Christina Nowla's at Glasgow University. Thanks, Christina.
Well, thank you. And thank you, Ben, for an interesting case and a really good discussion. I enjoyed that very much.
Thanks so much. Hopefully see you in March.
Yes.
I'm Vincent Racaniello. You can find me at microbe.tv. I'd like to thank the American Society for Microbiology for their support of TWiP and Ronald Jenkins for the music. Okay, Ben, now I'm going to do a little sign out. I'm going to say you've been listening to This Week in Parasitism. Thanks for joining us. We'll be back soon. And then you say another TWiP is parasitic. Okay?
Another TWiP is parasitic? Okay.
Yeah, after I say all this stuff, okay?
With enthusiasm.
With enthusiasm. You've been listening to This Week in Parasitism. Thanks for joining us. We'll be back soon.
Another TWiP is parasitic.